Hello, my friends. Hello, my friends from all over the world. It's a pleasure to meet, it's an honor to me to be here with you, today. And this is something that I love to do. Professor Kleber Merel is here speaking. First of all, I know all of you know me. So otherwise, you wouldn't be here with me today. So thanks a lot for being here with me today, for trusting my work, trusting my course to be with us in this moment, in this course, in this 8-hour class. Actually, I'm re-recording this first part of the class, this first part of our course, of our 8-hour class, because I had to do this to repair the first part, and I'm going to do some kind of editing to make everything perfect for you, okay? Because I had some trouble in this first part of the class. It was corrupt. Some part of it was corrupt, so I couldn't fix it. So I decided to do it again, which is good because I can do that without failure, and we can go on with the class and then the second, third, and fourth part. Okay, so this is a class. This is a course based on some topics that I've been receiving from all over the world, questions from people from all over the world, and some questions that are very important for orthodontic treatment because they are very clinical. So I decided to do this course based on those kind of questions, on those kind of doubts that my friends they have regarding some topics that are very important, as I told you. So here we start with the beginning of the beginning. Where I am, where am I, where am I speaking to you now? I'm from this part of Brazil. Brazil is this huge country in South America, as probably all of you know, and I live in this town here in the northeastern Brazilian region. This is Salvador, Bahia. This is a very beautiful city and a very colorful, very interesting city to visit. So if you have the opportunity to come here to Brazil and to visit my country, please let me know. So I'm going to show you proudly my city because I love this part of the world. I love this weather. I love this color, and this is something that I'm very proud of to show my city to my friends. Okay, so if you come here, don't forget, tell me about it so we can set something for you to visit this city. Bahia is a very interesting state because we have a weather, a very firm, very steady weather, very hot almost all the year, during all the year. And this is my city in this video from our state, from our government. This is where I live. So as you can see, we have a lot of colors in our city. And here you can see my family. We are a very happy family, thanks God. I have here my oldest son, Rafael. He's almost 2 meters high. And he's my youngest daughter, Maria Luisa, Julia, and this is my wife. This is my oldest daughter. Actually, she's now in graduation in dentistry. Julia is 18 years old. Here is Manuela, my wife, and here is me cooking, which is one of my passions that I love to do, okay? And rock, as you can see. So, let's start with our program. This program was made, like, as I told you, because I have some uh, questions coming to me around the world, people asking me about some things, about some topics, and all those topics, they have this importance, this clinical importance, as I say. And we will start with the bracket bonding, go into alignment and leveling. And about this topic, alignment and leveling, I'm gonna cut everything that doesn't matter for us, and we are going directly to the points that we do during alignment and leveling to overcome the problems of this stage of treatment. Okay, and then go into canine retraction, the problems that are generated in this part of the treatment, space closure phase, which is very, very difficult actually using any of the brackets, prescriptions, and ways of treating aligners and everything. We know this is the most important, most challenging part of orthodontic treatment, and we have to do many, many times since we treat many class 2 cases. So several class 2 cases are blocked during the retraction because we don't manage, okay, this kind of biomechanics during retraction. So I hope to show to you ways to overcome those problems during this class. And so at the end of our class, we're going to deal with a topic that is very interesting also, because we have to choose what we have to do, what's the best way, what are the best ways to deal with space, remaining space that we need to close or open, and some mechanics. Of course, we don't have time to do all the mechanics of molar uprighting, because for that we would need 8 hours, another 8-hour class for that, because we have to deal with the biomechanics, we have to deal with the pros and cons and each biomechanic, with each biomechanic that we use, and we have to put in the field to understand it. The periodontal status of the malocclusion, we have to put the occlusion itself. So there are many, many ways to deal with that, but I hope to clarify some of the choosing that we have, some of the ways to deal with that space closing or opening in those remaining space that we have in our occlusion. So those are the topics. Those 5 topics are going to be shown here separately, and we're going to start with bonding in orthodontics, which seems to be very simple. We do that almost mechanically, but we have some ways to uh, to view the problems, to deal with the problems before they appear, deal with the problem, the potential problems that can rise in this part of the treatment, and we dealing with that, we avoid its appearance. At least we avoid that it causes a lot of trouble for us during the treatment, during the rest of the treatment. So we have some topics to discuss here. One of those is the centralization of the brackets and tubes, and differences that we can put in our treatment in class 2 and class 3 cases. When we decentralize the position of the bracket, some situations can help us, okay? In some situations, it's allowed, okay? That's what I mean. In some teeth, specific teeth. The height and angulation should be carefully checked, and I'm going to show you why. Change bracket height in special cases. We can do that, yes, but we have to understand what happens when we do that. Change angulation in special cases, okay, it's very important also. And avoid excess is something that we do, or sometimes we don't do because we don't pay enough attention for that, and we have some insets that are embedded in this kind of situation. So let's begin with the start. Let's start with the beginning of our positioning of brackets. Centralization of the brackets is important, especially in anterior segment of the arch. We do the centralization in order to balance the position of the tooth, and in order to not to do rotations, because when we go out of the center of the incisor, for example, especially large incisors as the central incisors, upper central incisor. So sometimes we have this outcome. Sometimes we have the rotation of that central incisor that we can deal with the rebonding of the bracket, of course we can, or just adding bands at the arch wire, the leveling and the leveling arch wire, in order to correct the rotation. So we have those two possibilities. We can either rebond, or we do the new band, do a band in order to correct that, which I prefer to do. And I'm going to show you why I do that in most of my cases. Sometimes I put in my social media, sometimes I put these cases in Instagram and Facebook, and I have groups in WhatsApp, and people also ask me, why not just rebond? I consider a possibility of rebonding brackets. Yes, it's important. It's another possibility for us. But one thing that we have to keep in mind is that we need to have tools in our practice in order to achieve a better speed treatment, because we don't have to go back in our arch wire sequence. For example, if you notice that you have this kind of bad positioning, as you can see here in a rectangular arch wire, and then you go to do the rebonding, and then you decide that rebonding is the best thing for that patient. What you are going to do, you put the bracket in the right position, or you put bracket in a different position in order to overcorrect it. I don't know. It's possible. Either possibilities are possible. So are the possibilities you can do. So if you do that, you have to go back in your arch wire sequence. You have to go back to round wire, to not stiff round wire, but soft round wires, in order to correct that softly, because this is what you want to do. So you have to run the sequence again till you reach that position, that sequence, that part of the sequence that you were before, rectangular arch wire. So when we do that, in this case, for example, we don't need to go back in this sequence of arch wires. So we are speeding the treatment when we do bonding, when we do bands. When we do bands, we don't need to go back. We go forward. We go with another arch wire, and the next time when your patient come back to the next visit, we change for a stiffer arch wire. And when the corrector, when the tooth is corrected, or the group of teeth that we are dealing with is corrected, we have either possibility of rebonding, now with a stiff arch wire in a passive position, meaning I don't need to go back in the sequence, because I can put in position a stiffer arch wire, for example, a 1925 stainless steel, of course, in using a combination of a slot 2230, of course, so a 1925, using this position of the arch wire, the passive arch wire, to place the bracket in the right position. This is one possibility. Or we can go with the sequence of the arch wire, keeping the bands or increasing the bands if it is necessary, but not with the need of going back. So it can speed in the treatment. That's important for me. I almost never do the rebonding of the bracket just to correct one position. I do the rebonding of the bracket when I have that tooth corrected, and after that, I don't want to do bands and bands in the sequence of arch wires, because sometimes we need to do torque, sometimes we need to do other bands to do the perfect positioning or almost perfect positioning of our teeth. So if we have many bands in our arch wire, it may be difficult for us to deal with. So sometimes we do that, correct that position of teeth or tooth, and then we go rebonding in a passive position with a stiffer arch wire. This is what I do. So this is what I wanted to explain, because we will see during our alignment and leveling phase that I'm going to do that much. Okay, so we can do the correctioning. We can correct the positioning of our tooth. This is other thing that we see a lot, especially in our post-graduation programs, because we know that to understand the bonding, to do the bonding, I'm talking about the direct bonding here. We can, of course, we can do indirect bonding. It's another possibility. Yes, it is. But with time, I really don't think you are going to do that in your practice unless you have a big clinic with a lot of employees, and this is something that can be applied in this situation. But you don't have it. If you use your practice in a private clinic and you are one person seeing all the patients, it's not that easy to do that. I think you keep you have many things to do, so it's one more thing to consider. So when you go in your sequence of learning, you are learning more and more and more, and at some point you see that you can do that without the need of positioning those brackets in an indirect way. Okay, so this is what I think, at least. And here we see in our post-graduation program many students doing that, because they are sometimes afraid of doing the squeezing of the bracket in order to remove the excess of the composite. So sometimes they leave this kind of composite in one part of the base of the bracket base, and it will work as an inset band, because we have now a thicker base that will pull this part of the tooth inwards. So this is something that happens a lot, and sometimes we are just able to see that, to notice that when we reach stiffer arch wires, like a rectangular arch wire, for example. So we have to deal with that also. Apart of the centralization of the incisors, sometimes we need to deal with the class 2 and class 3 cases to correct the positioning of those cusps. We can change a little bit the positioning of the brackets, decentralizing it. So sometimes it can help us, because when we centralize, we know that the cusps are going to be even, are going to be completely perpendicular to the arch wire. But when we change it, when we change the positioning of the bracket, for example, in a class 2 case, which is very common for us, what can we do to help us to correct and to increase and to facilitate the intercuspation at the end of treatment? What do we want when we are treating a class 2? For example, a mild class 2, like 1/3 of class 2, comparing the position of the premolars. So we have approximately 2.5 millimeters of sagittal error. And if we do this, that I do frequently, if we position the bracket a little bit more mesial, if we flee for that position, if we escape from that position of the center of the crown, and you go a little bit mesial, what are we doing to the class 2 patients in the upper arch, of course? And we don't need to do that in the lower arch, because of the anatomy of the premolars in the lower arch. They won't help a lot, but in the upper arch they will help. So when we go a little bit for moving our brackets mesially, we are going to rotate a little bit those crowns distally. The tip of the crown is going to be positioned a little bit distally. So this is something that I've been doing for a long time now. I learned from Professor McNamara in a course that we gave together some years ago, and that's something that I'm using a lot, and it's in his book also. Okay, so we see that when we do that, we can rotate a little bit that teeth, that set of teeth, the premolars, and they go distally, and it will help the adjustment. It will help the intercuspation, especially in the second premolar, which is a very variable, which has a very variable anatomy. Okay, this is something that helps us in settling those cusps. Okay, and here we have, as you can see, those brackets are a little bit positioned more mesial in both segments here, and it helps a lot in cases when we want to do this beautiful intercuspation, as you can see here. So now we have this beautiful and this solid intercuspation, and this is something that can be achieved easily, not easily, but a little bit easier when we do this positioning a little bit mesial when it's a class 2. When it's a class 3, of course, is quite the opposite. We go distal in our positioning of premolar brackets, and they will rotate mesially. So those situations help us when we're treating mild class 2 or mild class 3 cases, and helps in adjusting the cusps, the position in the intercuspation at the end of treatment. So believe me, you will facilitate your intercuspation doing this kind of procedure here. For the positioning of lower canine bracts, I always do this. Always do that because it's something that is very common, that you don't tackle the companies that sell us the bracts. They have in the base of the bracts more thicker bases, thinner bases, according to the position and the thickness of the teeth, the tooth, and according to the thickness of those teeth, they will embed, they will position in the base of the bracket. As we know, depending on the prescription, there are differences, but they put a thicker or a thinner base in order to coordinate, in order to achieve a better adjustment in alignment and leveling of those crowns, okay? So, but sometimes they don't tackle all the variability that we have in human race. So sometimes we have a thicker canine, lower canine, and when we put this bracket in the center of the canine, we're not helping the adjustment because this thicker tooth will be pulled inwards when we do the alignment and level. Let's see how it goes. So in this case, when we don't have this base, this difference of the base thickness completely adjusted in our brackets, we pull the canine inwards. So this is something that's important. And some patients, they see that and say, isn't it a little bit inwards? Isn't it a little bit out of the alignment, doctor? And we have to say, yes, it is a little bit out of the position, and we have to deal with that. So as you can see here, when we go a little bit more mesial, when we position this bracket mesially in relation to the centered position, we can go like in a position that is more inwards and more a thinner position of this tooth, and it goes outwards when we level and align those brackets, okay? Those teeth, I'm sorry. So as you can see, comparing one side to the other one, we see that when we positioned in this case specifically, when we positioned in the center of the crown, it went inwards. So we have this step here. Looking from above, we can see that it's not completely aligned. So now we have to deal with this, and it's very easy to do that. We can do bends for that, or we can rebond the bracket, of course. Again, I consider the positioning of the bracket, repositioning of the bracket a little bit more less intelligent during our mechanics because we lose time with that. So what I do, as you know, is bend all the time. So this is a canine eminence band that I'm going to show you a little bit later. And here, as you can see, we now have it completely aligned because we dealt with that doing the bend, okay? But we can't avoid doing the bend. So if you think forward, if we plan, if we anticipate the problems that we can have in mechanics, we can deal with the mechanics, avoiding losing time, avoiding spending a lot of time doing bends, doing torques, doing everything. Of course, we need to do that almost all the time. I don't remember one case in my practice in which I didn't have to do the individualization of some kind of individualization, like bands, torques, loops, or everything together. So I do that very often because I consider that the individualization has to be done in almost all cases. It's very uncommon, if not impossible, that you do since the beginning going to the end to have that perfect intercuspation, perfect torques and everything. It's almost impossible to do that without dealing with bands, loops, torques and everything, elastics. So sometimes you have to do all together in order to have the best intercuspation that we can do, that we can give to our patients, okay? And for me, it's very important to do that. Let's see, okay? So height and angulation should be carefully checked. Yes, it should, because when we put our bracket in position, the companies that made that bracket in relation to the prescription that they are applying to that bracket, that prescription in all, not in all cases, but in almost all the cases that we use, especially when we use, for example, Roth or Andrews, they are planned to be the brackets. I mean, they are planned to be positioned at the center of the crown, because the reading of the torque, the reading of the inset and offset, the angulation, they are calculated for that position. So for example, regarding the torque, when we change the position, we have to pay a price for that. The price is we are changing the angulation that was thought to that specific bracket. So if we do that, because we know the prescription has the inset, the offset, the angulation, and the inclination, which is important in this kind of thinking that we apply now. The inclination, meaning the torque that is embedded in that base of the bracket, will change. The base of the bracket is where we see the inclination. Okay, we can have a zero inclination, as we have, for example, in edgewise appliance. We can have 3 degrees. We can have more than that, 7 degrees, for example, 22 at 12 degrees, and we go up to 20 degrees, 22 degrees. We can have those different inclinations embedded in the base of the bracket, as we know. So for most of the cases, for most of the scenarios that we have in prescription, they are thought for the center, for the positioning of the bracket in the center of the crown. What happens when we change that? As you can see here in this example, if we put a full wire, meaning a 1925 or 2125 arch wire, rectangular arch wire inside the slot, the reading of the inclination will be very accurate. So we have different inclinations according to the bracket prescription that we are using. So those will change according to the prescription that we are using, that you chose for that specific case. So if you want to have that prescription, and I know you know that is important for doing the finishing of the case, you need to understand that when you change the positioning of, which is very common, for example, in open bites, in anterior open bites, in non-overbite, we can do that. We put inside more closer to the tip or closer to the gingival margin, and those things we do. But when we apply, when we insert a rectangular arch wire in this situation, what is going to happen? Let's see now. So this is the position that's meant to be, the bracket is meant to be positioned. And now I want to do something different, because those patients will have to be correct vertically positioning of the crown. We will need to correct the crown vertically, meaning I'm going to extrude that tooth or that group of teeth. And for that, I position my bracket a little bit more closer to the gingival margin. Okay, so when we do that, yes, we are helping the vertical, but we are applying, when we put a rectangular arch wire, a different torque. And torque, it will generate a couple. Remember, a couple is a free vector. So what happens when we put a bracket in a rectangular bracket, in a rectangular slot, we put a rectangular arch wire and it will apply a couple. Well, it will rotate that teeth, that group of teeth. It will rotate, meaning we go with the crown palatally and the root buccally. Yes, that's the only way that the thing will happen, because the torque applies a couple, and a couple will be those two forces that will generate a rotation, a pure rotation, being the center of the rotation located in the center of resistance. So this is important for us to understand. Of course it is, because when we do that, we are going to deal with, after doing the torque, we're going to deal with the anteroposterior positioning of those teeth. So if they are very vertical, so if they are very uprighted in their base, now I go like this, retraction, and for that I have to deal with the inclination, which is now very vertical. So now I have to deal with torque, active torques for that. So this is something that I need to do, of course, but I prefer to do that in another phase of treatment, meaning the retraction phase. And when I do that, in order to change the inclination, I can choose in which position I want to put the center of rotation. The center of the crowns, the apex of the crowns, the tip of the crowns, the apex of the teeth, I'm sorry, the tip of those teeth, or in the center of those teeth. I think you can understand that the best position, if you have a very proclined incisors, is put in the center of rotation in the apex. So you can't do that using just a torque. I'm going to show you during the retraction, okay? So we'll see it a little bit later. But as we see here, when you insert a stiff rectangular arch wire inside that slot, which is now giving a different reading, a different inclination, different from that was thought for that practice. Now we deal with a active torque in this anterior portion. So now what's going to happen when you put the arch wire inside the tubes, inside the posterior teeth slot? It will generate a rotation. As I told you before, we have just torque here. We don't have a distal force. So meaning just torque, it means that we had just a couple. Couple will generate the rotation. So now we have crown going palatally and root going buccally. Is it possible? Sometimes it is not. Especially when we have this increased proclination of anterior teeth, huge proclination of anterior teeth, and we do that when you insert the rectangular arch wire with neutral torque that we're going to deal with a little bit later. When we do that, we are going to generate this huge torque, huge tendency of inclination of the crown palatally and the root buccally. But do we have enough room? Do we have enough bone buccal to the surface of the root to do this kind of inclination, to do this kind of pulling the root against that cortical plate, thick cortical plate? I tell you, we don't have it. So it's not good. We have to understand how to do the correction of the inclination, and it's not now. It's not inserting the first rectangular arch wire. Believe me, you don't want that, because it will make you it will make you very in a very bad situation to do the retraction, because now you have uprighted teeth and you have to do this kind of retraction without losing further inclination at all. It's difficult. You have to put a huge torque for that, and it's very difficult to control. So you leave this teeth proclined in this phase and deal with the retraction in another phase. This is the most important thing here. And what about the posterior teeth? Same thing, sometimes worse, because in posterior teeth we have more torque and we have more convexity of the crown. So let's see, comparing 3 different relative torques with just one neutral torque. Neutral torque, you know, it means that we have no torsion at all in our arch wire. It's the torsion 0 of our arch wire. So we insert our arch wire, rectangular arch wire, inside the slot of posterior teeth, especially the tubes of molar tubes, and rectangular arch wire neutral. It will make the crown in its perfect position if the crown is perfectly positioned, okay? But this will happen only if you position the tube in the right position. If you put the tube in the right position during bonding. So let's see how it goes. So as you can see, it's completely centered now. We put the tube in the right position here, bonded in the right position, and we are applying a neutral torque of the arch wire. So perfectly positioned bract tube in this case, and perfectly inclined crown and root in this molar, okay? keeping the molar in this position, perfectly positioned. Now we are going to change the height of the tube. What is going to happen? Look at this. Not changing the inclination of the root, not changing the inclination of the crown. It's perfectly inclined, and we would like to keep it, to maintain this teeth in its position. But I put the tube a little bit higher. What's going to happen with neutral torque, meaning no torsion of the arch, and now I'm going to insert it here. As you can see, now we have an active relationship between the root, between the slot of the tube and the inclination of the rectangular arch wire, which is now inclination 0, and inclination of the tube is different because we escaped from the center position to a higher position. So we changed the inclination of the slot here. Okay, and now we have an active torque, a relative active torque, which is a buckle crown torque. Okay, and now we go in the more common situation. Sometimes we escape from the center because we see that when our patient is closing the bite is biting, when we see that patient goes like this, the upper tip of the crowns, they go like they avoid you to do the right positioning. So sometimes you say, no, let me go a little bit more apical in this positioning of the bracket. What happens when you go like this? This is what's going to happen. You are going to generate a relative torque. Now, in the opposite direction that before, you're going with the root buccally and the crown lingually. So this is something that's going to happen all the time when you put a stiff rectangular arch wire inside the slot that is very, very lower positioned, a bracket that's lower in its position. So we change the inclination using just the positioning of our brackets or tubes. In this case, we have 3 different inclination of the same tooth, using just a neutral torque, meaning no torsion of the rectangular arch wire, but changing the height of the tube, the height that we have positioned the tube. Okay, so we have 3 different possibilities just with one real neutral torque and 3 different heights of bonding the tube. So this is something that we have to keep in mind, because every time you do that, you are going to generate that kind of thing. Okay, boom, beautiful. So can we change the height in a specific case? Yes, we do that a lot. We do that a lot because we know that one of the topics that we have to correct, one of the things that we need to correct, especially in those patients that show gingival margin, is to do the leveling of the gingival margin. And we know what we want, what lay people want, what orthodontists want, what we see as beauty when we see gingival margin at smile. We know that central incisors are higher than lateral incisors, and central incisors are at the height of the canine, or the canine a little bit higher than the central incisors. And they have, especially in central incisors, to be even. The margins need to be even. So for that, sometimes we need to do the positioning of the bracket in different height. Why is that? Because we have 2 possibilities when we have this difference in gingival margin. Here, for example, we have the central incisor, the tooth 11, higher than the tooth 21. Okay, so this is something that we can deal since the beginning of the treatment. Okay, we can plan in this case to do the gingival margin, to do the surgery, the gingival margin. But if we do that and we expose the root, if we do that and for doing that, we need to expose the root, now we have to do a crown for the teeth, at least we call contact lens, at least a veneer in this teeth to make it, to protect the root, as we know. And another thing important here, sometimes we have to do osteotomy. And we don't do just the osteotomy in this tooth. we need to go to the neighboring tooth. So we create a difference between the root, inside the bone, and the lever arm. So if we do this, if we need to do the osteotomy, we're not sometimes not doing something good for our patient, because we have to do this in the neighboring teeth also. So for that, we have to have the indication to do that, meaning we have to have a pocket here, and we need to have a pocket, a periodontal pocket here, so we can do this surgery. If we don't have it, and it's very common that we don't have it in cases like this, in crowding situations, because what happens, most of the crowding situations is a difference in wearing the tip of the tooth. Wearing, it's very different in height, because this contact, this friction, and different teeth, so they have different inclination, and they have this extrusion during life. So it will extrude, and when it goes wearing, and they will extrude in different heights, in different magnitude, because this tooth here, it was worn more than the other one. So when it happens, the extrusion that happens during all the life, it goes with the margin, the gingival margin together. So teeth, or in this case, this tooth, it went down with its gingival margin, meaning it's not a periodontal problem here. It's more something related to the occlusion. So for this patient, it's best for him to do the intrusion of this incisor. And after doing that, after intruding this incisor, we don't deal with it now. We intrude it, and you will have a shorter crown, meaning this crown will be lower than the other one, but patient is aware of that. We have explained before the treatment that it was going to happen. This was an outcome that was expected for his case. And after that, he's going to do the resin or veneers or anything he wanted. So he knew that. And we can do that since the beginning of our treatment in order to avoid doing lots and lots of bands. So what do we do here? Okay, we anticipate the problem, understanding that if we position our bracket of central incisor in different heights, we can level the gingival margins. What was exactly what we wanted, okay? Now we have it. Okay, gingival margins here are uneven, and for that, we are not applying the concept of doing the centralization based on the tip, even though it is centralized, because this tip here is shorter than the other one. So if you consider the center of the crown after doing the resin here, it's almost, or is exactly in the center of the crown after doing the lengthening of the crown, okay? So here we can do that since the beginning, and we avoid lots and lots of bands. Of course, you can do bands, as you can see in this case. As we'll see in this case, we had to do bands to correct perfectly the margin, the gingival margin. But sometimes we want to avoid that, and for that, we did this leveling and aligning and bonding the brackets in different situations. So as you can see here, in order to go upwards, in order to go with this gingival margin higher than the lateral incisor, we did also a band here, an intrusive band here, and we'll see this band a little bit later. And then we know now that we have the gingival margins even, they are even, but the tips are not. It was expected, as I told you, and patient knew that before, because you cannot surprise your patient doing like this and say, oh, now it's better for you to, what? Are you crazy? It's my teeth are not even. And sometimes he just see that. But if you do that, if you think forward, if you plan everything and tell your patient everything that's going to happen during treatment, he will understand, she will understand, and he will be a partner in your treatment. Okay, so here we have, and after that, during the treatment, we can do that provisional lengthening of the crown. Okay, and then after treatment, he will go to the definite crown. Okay, to the permanent crown, to the permanent resin, and or something that he wants to do. Okay. So my friend Yuri here, as you can see now, the crowns are with the same length, and the gingival margins are even. Of course, we have some errors here. I could have done here a little bit more palatal crown torque in the lateral incisors, but in this case, if we pay attention to this topic specific, which is the height that you can bond the incisors, and here we have the gingival margin still even 4 years after treatment, and the intercuspation, it kept its position. Okay, so as you can see here, we have the tips and even, and the gingival margins also even, and I regret not having done the torque here in the lateral incisors, but we commit mistakes during our treatment. Okay, so before and after, here Yuri after a while, I think it's 4 years after treatment, and showing his beautiful smile. Okay. Regarding the positioning of bracts, there are some situations that we need to choose the right positioning of our bracts. We need to choose what to do in some situations, just because when we choose the right tube, for example, we can save time in our treatment, not having to do bends for correct the angulation of the molars. Sometimes we are going to finish our treatment in a class 2 position of the molar. In which situation do we have that? And when we close spaces, when we have lateral upper lateral incise absence, congenitally absent lateral incisor, for example, when we close spaces, or when we extract just upper premolars, we'll end up with a class 2 position of our molar, which is normal, keeping the position of canine and premolars in the class 1, and a good overjet center position of the midline, everything okay. Just that is changed. We have the position of the crown of the second molar more uprighted. We need that. And for doing that, we need to choose the right tube for that. Because we know that the class 1 tube, it comes with approximately 5 degrees of angulation of it, and rotation of 10 to 15 degrees. When you look from above, you see that the tooth is rotated. The molar is rotated because it provides a better settlement when it's rotated. The distal cusp of the molar, the upper molar, in between the first and second molars, okay? Lower molar. So in this situation, in a class 1, we have everything set for us embedded in the tube. But we don't need that for a class 2 finishing. If we are going to do a class 2 finishing, we need to choose a better tube for that. And we have those tubes. For example, if we use a MBT tube from lower arch, which is minus 10 degrees, when we choose that tube, and we just flip that tube to upper arch in the opposite arch. For example, we use the left lower tube, MBT, minus 10 degrees, in the upper right segment of the arch. So meaning the 36 goes to the 16, okay? So we can change it because we put the hook in the right position. When we do that, obviously, we can change so for lower left tube to the right upper molar, okay? Meaning we have to have that 10 degree, minus 10 degree for that. When we have that minus 10 degree, we go approximately what we need in the upper arch, which is minus 12 to minus 14. But when we consider the play inside the slot, it's okay for us. When we consider that we don't read completely the torque that we have, we are in this margin of not doing the torque, okay? So minus 10 degrees is good for that. So think about it, your prescription. If you have a minus 10 in the lower arch, you can go up. So we just do this, lower to upper in the opposite MI arch, okay? So in this case, we keep the inclination, -10, but we don't need the angulation, which is normally 5 degrees, and we don't need the rotation, which is normally 10 to 15 degrees. Usually is that we have in the average prescriptions that we use, okay? So let's see how it goes. When we want to do that, when we want to correct the class 1 position of molars, premolars without extraction, or in situation that we don't have the absence of lateral incisor, we're going to finish in a solid class 1 position. That's what I mean. That's what I mean. So in this case, we need this inclination, we need this angulation, we need this rotation. So we need 3 things that we have embedded in the bracket, in the tube of the first molar. In this case, let's see how it goes. When we have a class 1 finishing of molar, the tube that we use for that, it has this 5-degree angulation, mesiodistal relationship. In angulation, it means that we are going to put our cusp here lower, the distal cusp, lower than the mesial cusp, okay? And it's good for a class 1 finishing. Let's see how it goes. So this is what we do, and now we are finishing in a solid class 1. You know, in the past, we called that a super class 1, because we have this beautiful settlement in the distal cusp. The marginal ridge of the distal marginal ridge of the upper first molar is setting on the mesial marginal ridge of the second molar. And this is a very solid class 1. And it allows the teeth in front of the molar to settle to a better settlement also. So this is very beautiful, very solid intercuspation. For a class 1, perfect, okay? For a class 1 finishing is perfect. As you can see here, it's one of the topics that I seek. It's one of the position that I seek, that I want to have, is this contact between the upper marginal ridge of the first molar, distal marginal ridge of the upper first molar, contacting the mesial marginal ridge of the second lower molar, okay? Beautiful, solid, and this is something that I can see that in my view, of course, we don't have that kind of research comparing that, if we don't have completely settlement of this cusp, and what is going to happen with time. Is it more stable when we have it or not? But I have this feeling. I have this feeling because we know, we go seeing this patient a long time. We go seeing this patient 5 years, 10 years, 12, 20 years after treatment, and I have now, I'm at an age now that I can see those patients 20 years after finishing treatment, and I see that it keeps the position of those posterior region, of the posterior segment, okay? Not anterior, of course, because we have sometimes a relapse anterior teeth, but it's completely different. Let's move on. Hope you are understanding everything. Hope you are liking till now our lecture. So let's move on. But when we finish in a class 2 situation, for example, when we are going to extract a premolar, which is pretty common, unfortunately, people think that it's not. Some people say that we don't use that anymore, and there are some kind of battling between extraction and non-extraction cases. But I think it's a little bit stupid, because we know that sometimes we need to extract, because we don't choose that. The problem chooses it. The problem must be addressed. The treatment must be planned according to the best thing for a patient. So sometimes we need to extract. I'm going to finish it here. I don't want to cause any trouble in your mind now, but I extract sometimes because I need to. So if I have to extract, going back to our case here, if I have to extract in this situation, and now I'm going to finish in a class 2 position of our molar, not in a class 1 position. because I extract just upper arch. And if we have a class 2, is that what I want to do in almost all cases. I want to extract just in the upper arch. Yeah, sometimes I need to extract in the lower arch, but we'll deal with that later with some kind of tips that I'm going to show you, some kinds of choosing that you have to keep in mind when you do the extraction in class 2 cases in the lower arch, because it may jeopardize your finish, your face, okay? Your patient's face, of course. But let's come back to here. In this situation here, when we close the space, when we want to do this finishing in a class 1 in canines, class 1 in premolars, and a class 2 in molars. Now we don't need anymore that angulation. Now we don't need anymore that rotation that are embedded in the tube of that molar. So now if we choose a 10 degree, which we find very easily in a MBT prescription. So when we use this 10 degree, or here in Brazil, we have here some prescription that anticipate that, and you choose, I want a tube for class 1 or for class 2. But I know that in many countries, you don't have it. So you can have the MBT prescription for that, which is very common in many, many countries. So you can choose the upper or the lower tube to the upper molar. Just change the position and the cross position. You go to the other part of the arch. So now we can change, now we can choose, and we can shift since the beginning. Of course, since the beginning of our treatment, we can choose this tube. Not anymore the 5 degrees, but a 0 degree angulation tube. And it has 0 rotation also. So we can allow now for a better settlement of this molar, because now we have a more uprighted position of the molar, because we want now to have this, okay? Sometimes we need to adjust with bends, more going more buccally or more palatally with this, but just to have a better settlement. But it will help you. Definitely, it will help you. The right choosing of the tube for a class 1 or for a class 2, because I've seen that a lot. I've seen that a lot in my post-graduation programs and transfer cases. I've seen that a lot. People don't choose that. And we have, at the end of the treatment, that difficulty in settling the cusp of the molar, and all the teeth in front of the molar, it will suffer the same process, because we have a disocclusion because of the lower cusp, the distal buccal cusp of the molar. It's lower than the mesial buccal cusp. So sometimes we need to do bends to correct that, and we need to do first order and second order bends to correct that, because we didn't choose the right tube, okay? So we can anticipate that problem doing the right choosing. That's it. So if you compare those two cases here, a class 1, a solid class 1 positioning of our molar, as I told you before, this cusp is lower than the mesial cusp, and it allows for a better settlement of the marginal ridge of the upper first molar with the lower marginal ridge of the second molar, okay? The marginal ridge of the lower second molar. In this case, you can see, as you can see, it is inwards. This cusp is inwards because of the rotation. And now we have the opposite here. The cusp is outwards, and we have this vertical position of the upper first molar, okay? So this is something that you can easily avoid, to do all those bends, all those torques, all those things that we need to do if we choose the right tube for that. Now I'm going to show you this in a video for you to see some situations that we can anticipate in our treatment. This goes like a video. I can't stop it because it's very heavy, and we already have for this presentation more than 1,200 screens, 1,200 slides. So sometimes I have to concentrated in just one video, not a series of slides to show that. So this is a video that shows some possibilities of choosing before initiating treatment, how to deal with angulation, the right prescription that you want to do, the right tube that you want to choose. Let's see how it goes. So in this case, so a case of a patient that I treat closing the space because she has this class 2 and I need to retract. So I chose to do this space closure. As you can see here, a large space to be closed. So in order to anticipate what's going to happen during space closure, and we know what happens, and if we apply this kind of force at the level of the crowns, we tend to rotate, we tend to lose torque, and everything has to be thought forward before doing the treatment, in treatment planning. So in this case, the class 1 tube wouldn't help me a lot, even though we are going to finish with a class 1 position. But in this case, the angulation embedded in that tube is going to throw the root distally and the crown mesially. But it is going to be accentuated by the traction, the mesial traction. So what do we do in such a case? To finish with the molar more vertical positioned, we can change for a zero angulation, and we do a more procline, inverse angulation, meaning we go distally with the angulation, pulling the root mesially, pushing the root mesially. And the same thing we apply to the premolars. We do the angulation during the bonding, tending to do this kind of positioning of the roots, because the force that is applied at the level of the crown will tend to do this. So we are anticipating the problem, trying to do the opposite, like I'm trying to do this kind of angulation, premolar, and molar in this position. And we will tend to avoid that huge loss of angulation during the closure. So those are things that we can think before doing the bonding. We can think that, we can anticipate the problem, and doing that, we will avoid, or at least we will decrease the need of doing many bands and different adjustments that take some time for us to do. As you can see here, the molars are almost uprighted during closure, and a huge space was closed here, and even being so big space to be closed, the molar, it kept almost vertical during the retraction, during the space closure. And also the same thing happened with the premolars. So those are just tips that we have to keep in mind. Those are situations that can help us a lot when we do that, because we avoid doing too much things. Let me show you just positioning of as you can see the video here, you can go like this. If you compare here before and after, of course, we could have done more angulation of the crown, of the premolar, distal angulation of the premolar, and all those things, but I consider that pretty good when we compare to the space that had to be closed, okay? So this is just one tip for you to understand that since the beginning of our treatment, we can save time for our finishing if we choose the right situations. So I can't just think about other possibilities. Of course, there are other possibilities. I'm just tackling here the possibilities that are more common when we finish in the class 2 position. Absence, congenitally absence of lateral incisors, and we have to close the space. So all those possibilities, we can deal with that, and we will see more details about the closure, about the canine substitution later, okay? We'll see that, but for now, you understand that we have some situations that we can apply just in the beginning of our treatment in order to speed up our finishing. in order to treat in less time. So this is very important for us because treating less time means less cost for your patient. It means less chair time for you. It means that you are less. It's the root resorption that we know that's time related and force related. We will have less magnitude of tooth resorption, probably root resorption, probably. So all those things are important for us when we anticipate the problems that we have during our mechanics, and we deal with that. We deal with that doing this kind of changing in angulation, in position, and but it comes with a cost.